All right, guys, we're going to talk about sodium balance in this little segment. So sodium is really important to balance out because it's the primary solute that is going to set up your osmotic gradient. It's critical for normal osmotic pressure, and to keep the amount of sodium in your plasma and interstitial fluids is critical. So the words for too much sodium: hypernatremia, too much plasma sodium; hyponatremia for too little plasma sodium. The places where we reabsorb sodium, right? 70% in the PCT. So most of our reabsorption of salt takes place in the PCT. And then the remainder is going to be in the distal convoluted tubules and in the collecting duct. Okay. Our loop of Henle is very involved in that countercurrent multiplier system. So we're not really going to talk about that anymore. And then the movement of sodium is going to be regulated by aldosterone and atrial natrietic protein, so two hormones. So we're going to start looking at just one concept before we move on to aldosterone. Just realize that the sodium-potassium pumps here, okay, this is active transport, and it's going to move sodium out of the cell back into the bloodstream and potassium from the interstitial fluid into the cell. So ultimately, what the sodium-potassium pump does is create a high concentration gradient of potassium in the cell. You guys already know this. And just reminding you that a low concentration of sodium inside the cell. So there's going to be a natural gradient, right? Since sodium is low inside the cell, there's going to be a natural gradient for sodium to leave the tubular fluid and enter into the cell. So this is created by our active transport. So the movement of sodium down its concentration gradient is considered secondary active transport. Right? Secondary active transport because the ATPase pump, right, sodium potassium pump, set up that concentration gradient. So the concept here is the more sodium potassium pumps you have, okay, this is the action of aldosterone. When aldosterone is secreted from the cortex of the kidney, okay, adrenal cortex is the source of aldosterone. Aldosterone is stimulated two ways, let's just say. Stimulated two ways to get aldosterone. Number one is a very high potassium concentration, a lot of potassium. You ate a banana. The other big factor is angiotensin 2. Okay, haven't talked about that yet. So that's going to secrete aldosterone. Aldosterone is a steroid hormone. So notice that it just kind of leaves through the membrane. It goes in the membrane of our tubular cells, and it's going to enter let's call it the correct name, principal cell. These are principal cells that act to balance our sodium and potassium. So the intracellular receptor for aldosterone, right, inside the cytoplasm. And then you can see how aldosterone does two things inside. So it's going to set up more, let's just talk about the pump first, more sodium potassium pumps. Okay, so what is that going to do ultimately? It's going to create an even greater concentration gradient difference. So it's going to pump sodium out and it's going to pump potassium in, all right, from the interstitial fluid. So again, where is potassium high? That the adrenal cortex is getting the signal that potassium is high from the bloodstream, right? We have a lot of potassium in our bloodstream. So that triggers aldosterone. Aldosterone is going to remove, so this potassium will come out into the interstitial fluid, remove that potassium. The potassium is going to have a high concentration inside the cell. Higher now because we have more pumps. That is going to drive the diffusion of potassium out into the lumen of our DCT or our collecting duct because we want to get rid of it. We have too much potassium in the bloodstream. We want to get rid of it. So the other thing that aldosterone does is it puts up even more of these potassium leak channels, right? So we're driving the potassium concentration higher inside the cell because we have more pumps, and we're also creating more exit doors, right? More exit pathways for potassium. So the number of potassium ions are increasing in the tubular fluid, which will ultimately become urine. The other byproduct here is that the sodium concentrations, because we do have that pump running, is going to go down, right? We're pumping sodium out. The sodium is going to go into the bloodstream. Now, what happens when sodium comes into the bloodstream? It draws water, right? Solute first, then water. So more sodium in the bloodstream, water will follow. So aldosterone has this effect, two effects. It has the effect to, one, secrete excess potassium, okay? So excrete excess potassium. The second effect aldosterone has is to increase our blood volume. Okay, it's going to indirectly, right? So it's going to help more sodium move into the blood. And that's going to, water follows. Okay, so that's aldosterone. So I'm just looking at your notes to make sure I covered the pumps, the channels. We have an increased secretion of potassium lost in urine, increased reabsorption of sodium, right? That's what I'm doing here, increased reabsorption of sodium, and that's going to increase our blood volume and blood pressure. All right, now we're going to turn our attention to another big system called the renin-angiotensin-aldosterone system, or RAAS. I'm going to look at this one first. So how does your kidneys know what's going on with the solute concentration in your filtrate and in your blood? So the macula densa, remember, where was the macula densa? Macula densa is a collection of cells in your afferent arteriole, all right? And it can detect the amount of sodium and chloride, moving through. The macula densa then can talk to a collection of cells called the juxtamedullary cells. Now, I know the notes say granular cells of the juxtaglomerular apparatus, but you can just say juxtaglomerular cells. Juxta, which is not that much of a difference. Juxtaglomerular cells. So the macula densa talks to the juxtaglomerular cells with a paracrine. Paracrines are just little molecules secreted. The locally acting hormones are going to tell these juxtaglomerular cells to secrete renin. What is renin? Renin is a proteolytic enzyme. It's an enzyme, and it's going to cleave angiotensin 1. Now, where does angiotensin, what is this system? Okay, so the liver creates this protein called angiotensinogen. We have seen this kind of suffix before, inogen, right? Fibrinogen, pepsinogen. This is an inactive form of angiotensin. So angiotensinogen is inactive. It becomes activated with renin. So renin's going to come in, it's going to cleave or cut one of the parts of angiotensinogen off, and that's going to activate it, and that's going to become angiotensin 1. So angiotensin 1 is halfway there. Angiotensin 1 needs to get another chemical reaction done, and that's by ACE. So ACE is called angiotensin converting enzyme, and ACE is actually found on the walls of your endothelial cells. So on the blood vessel walls, very high concentrations in the lungs, but throughout the body. And this is going to convert angiotensin 1 to angiotensin 2. Now this angiotensin 2 is the one that does a lot of work. Angiotensin 2, if you look at your notes, there are 4 different fallouts, so 4 different effects that angiotensin 2 has. And all of them are going to increase blood pressure. So angiotensin 2 is a big increase in your blood pressure, okay? So all of this RAAS pathway, this is to increase your blood pressure. So obviously the stimulus to kick off this chain of events would be low blood pressure, right? A drop in blood pressure, a drop in blood volume. And so that is going to reverse it, right? Reach homeostasis. So angiotensin 2 has 4 things it does. You can see in this drawing, if we just want to finish this picture here, it will stimulate those cells that secrete aldosterone to produce aldosterone. And we just saw what aldosterone does. What does aldosterone do? Aldosterone is going to secrete potassium, and that's fine. That's not what we want to, in this pathway, it's not important. It's going to secrete potassium, but it also, what does it do? Reabsorb sodium. And that reabsorption of sodium is going to have water follow it, right? We're going to reabsorb water, and that's going to increase our blood volume, right? Increase the water. So it's going to kick up our our blood pressure. Here's the flow chart, right? So here's angiotensin 2. We can talk about the other things. So we just talked about aldosterone. So we just did this. Okay. What else? Angiotensin 2 is also a very powerful, by itself, acts on the smooth muscle walls on your arterioles to constrict, which of course increases MAP. It also is going to act on the posterior pituitary. It's going to secrete ADH. What does ADH do? It retains water. What does that do? It increases blood volume, which would increase blood pressure. It also talks to your hypothalamus to make you feel thirsty. So you're going to drink water to increase your blood volume, to increase your blood pressure. Okay? So out of this angiotensin 2 pathway, this RAAS pathway, two important aspects happen in the kidney, right? And that's where aldosterone works, and that's where ADH works. And those are to reabsorb water. So ADH is to reabsorb water. And in a indirect way, aldosterone acts to reabsorb sodium. Okay, so let's look at, so this is the mechanism, so this is the stimulus, right? So what stimulates this whole pathway? It's that decrease in blood pressure. That drop in blood pressure is going to go to three different pathways, right? So this is what we just kind of talked about with the kidneys. So that decrease in filtration rate and the decrease in detection of our solutes, that's the job of the macula densa. The macula densa is then going to stimulate those juxtaglomerular cells to secrete renin. Okay. Then other things that help to secrete renin is the baroreceptor reflex. So this is, remember that reflex when we have low blood pressure, our sympathetic activity goes up, and that's going to vasoconstrict all of our blood vessels that we raise at blood pressure. But another thing that the baroreceptor reflex does is it helps to secrete renin by those cells. Lastly, our afferent arterial pressure goes down, and it's also going to increase the renin. So the afferent arterial, right, this is where the macula densa is, and it's able to secrete renin. Okay, so these are the three factors that will prompt the secretion of renin, and renin is important because renin is the first link in this RAAS pathway. So let's look at this, right? So our liver will constantly have an inactive form of angiotensinogen in our bloodstream that is only going to get activated if there's renin present. So renin is the key. Once renin is secreted, it's going to convert the available angiotensinogen to angiotensin 1. Then ACE is always on your capillary endothelial cells. So you don't have to make these, they're always present. So if there's angiotensin 1, it'll get converted to angiotensin 2. And then angiotensin 2 will do those four different things, right? Going back to this is what angiotensin 2 does. And everything's to raise your blood pressure. Everything's to create hypertension. So angiotensin 2 will directly vasoconstrict or act on your kidneys to retain salt, but also water, which is not in here, and water. Okay, so there's medicines out there. If you do have high blood pressure, you don't want to activate this pathway, there's medications called ACE inhibitors that stop the enzyme that's on, they block the enzyme that's on your endothelial walls, right? They clog them up so they can't convert angiotensin 1 to 2. And then diuretics can take care of that. If you do have reabsorption of salt and reabsorption of water, diuretics can counter that. So you can lower the blood volume with diuretics. So there's two different medications that you can take with high blood pressure, chronic high blood pressure. Okay, so let's switch to the next hormone, which is the opposite, atrial natrietic protein. Oh, sorry, peptide. Protein and peptides often interchanged. Okay, so this is going to lower your blood pressure, but via lowering the salt. So we want to excrete the salt. So your blood pressure is high, or your plasma volume is high. The walls of your atria, right? This is atrial natrietic peptide. This is coming from the atria, the heart. So your heart's feeling it. The atrial walls are stretching. They're going to secrete ANP with this stretching. What does this hormone do? It works on the kidneys in these ways. So you can see that ANP can counter renin. So it's going to decrease the renin secretion, and that's going to then decrease aldosterone. When it decreases aldosterone, right, then it's going to limit the salt reabsorption. And if you don't reabsorb the salt back into your bloodstream, then the salt ends up in your urine, right? You excrete your salt. What atrial natriuretic peptide also does is it dilates your afferent arteriole and it constricts your efferent arteriole. So afferent arteriole, remember the afferent arteriole brings the blood in to the glomerulus. The efferent arteriole brings it out. So it's easy to come in, harder to come out. That's going to create more glomerular pressure. So while that fluid is coming into the glomerulus at a large rate, you're not letting it go out equally as fast. So you're building up that fluid pressure in your glomerulus. It's like having a 4-lane highway and you're only letting cars out one lane, like there's a parking lot. That parking lot's get jammed with cars. It's kind of like your glomerulus. So the water's coming in, it's being backed up in the glomerulus, it's building a lot of hydrostatic pressure. That pressure is going to increase the filtration rate of the glomerulus. So a lot of fluid's going to come out. And a lot of solutes with that fluid is going to come out. So it's going to then increase the amount of fluid coming out of your kidney, and then it can get rid of the salt. So this mechanism is to decrease the amount of fluid you have in the bloodstream. So this would be active when you have high blood pressure and you want to lower it. Okay. And that's part 2.